Honorable Chairperson, learned audience, Assalamu alaikum. I am Dr. Aminur Razzaque from NICVD, is presenting my case, the coronary calcium, a rocky journey. My patient, 50 years old, male, diabetic and hypertensive with history of recent MI antroceptal with ejection fraction 45% and normal kidney function, diagnosed as case of double vessel disease. This is the coronary angiogram findings showing left main normal. LED shows 90% stenosis from proximal to mid part with severe calcification. LCX more or less normal with large caliber OM, and RCA has 80 to 85% stenosis in mid part. So the proper planning is the key in this case. That is the appropriate patient selection, large guide catheter selection, strong guide support, intravenous imaging, atherectomy, and other plaque modification strategies. There are some tools for treating the coronary calcium, that the NC balloons, cutting balloon, scoring balloon, rotational atherectomy, orbital atherectomy, intravenous lithotripsy, and opium balloon. This algorithm is showing the plan of management of calcium. Depending on the score, the variables are calcium arc 180 degree to 270 degree, calcium arc more than 270 degree, calcium length more than 5 millimeter, and thickness more than 0.5 millimeter. If the if moderate to severe calcification with a score of 3 to 5 points, then we have two options: the lithotripsy and rotational atherectomy or orbital atherectomy. And if the lesion is impossible, then the rotational atherectomy is the choice. What the guidelines says, according to PCI, American Heart Association PCI guideline 2021, heavily calcified lesions plaque modification with rotational atherectomy is two-way indication, and heavily calcified lesions plaque modification with orbital atherectomy, balloon atherectomy, laser angioplasty, intracoronary lithotripsy is 2B indication. There are some comparison between rotablation and intravenous lithotripsy. That is the wire bias maybe in case of rotablator, and in case of intravenous lithotripsy, we can put a wire in the side branch also. But in case of rotational atherectomy, side branch wire must be removed during atherectomy. And usually we deal the superficial calcium with rotational atherectomy, and we modify the deep calcium with intravenous lithotripsy. So why we do not do the atherectomy? Usually we do not do the atherectomy in severe, if there is severe toxicity, thrombus, dissection, or any bypass graft vessel. So in our case, we do pre-dilatation with NC balloon 2 into 12 millimeter here. Then we do a IVAS before rotational atherectomy, which shows the calcium arc of 360 degree in proximal LED. And from ostium to distal part of LED, the MLA and the plaque burden shows that there is significant plaque ranging from 62 to 74%. So before doing rotational atherectomy, we were very concerned about some precautions about the adequate support and proper guide catheter selection. Usually 1.7 millimeter diameter bar, we can use the 6 French guide catheter, and in case of more than 1.75 millimeter diameter, we usually use 7 to 8 French guide catheter. Guiding catheter should be coaxial in position in order to achieve good support. radiopic tip of the guide wire should be placed as distally as possible. A single 1.5 millimeter diameter bar can be used in a wide variety of lesions. A pecking motion of the bar, that is quick back and forth movement, is always as advised, and the rotation of the bar speed is ranging from 135 to 180 RMP, and the short duration of the ablation is usually we follow the less than 15 seconds, but it should not be no longer than 30 seconds. And we have to avoid stopping and starting the bar in lesion, avoid stopping the bar distal to the lesion, avoid adjusting the RMP during ablation, avoid keeping the bar in one position while rotating in high speed, avoid advancing rotating bar to the radiopic tip, and avoid barring in the guide catheter. So in our case, the rotational atherectomy was done with bar size 1.5 millimeter with RMP speed of 1,50,000 to 1,60,000. And this is the angiographic view after rotational atherectomy, and the rota wire were exchanged with the help of microcatheter. And the post-rota IVA shows there is polishing reverberation and multiple cracks. So again we do pre-dilatation with NC balloon 2.5 into 12 at 14 atmospheric pressure, and then we put the stent Synergy 2.75 into 48. And this is the deployment of the stent. And post-dilation was done with NC Euphora 3 into 15 and NC Mojic 3.5 into 8 millimeter balloon. This is the angiographic view after post-dilatation. Then we again do the final IVAS. The MSA was good from ostium to distal part of the LAD, and there is proper expansion, no malapposition, no edge dissection of the stent. And this is the final angiographic view in my case. So my take-home message is rotablation is not a debulking technique, it is a plaque modifying procedure. Picking movement is the trick. Smaller bar, artery ratio 0.6 to prevent the vascular complication. Maintaining proper hemodynamics parameters during procedure is imperative to prevent the low flow, no reflow, and always prepare for procedural complications. I want to pay my special gratitude to my mentor, Dr. Mohsin Ahmed, who is a builder of young interventional cardiologists in Bangladesh. And I also want to thank my teammate. So a rocky journey which ends simply with rota ablation. Thank you all for patient hearing.
Thank you, Aminur Razzaque, for sharing your insight to us. Now is the question and answer session. First, the audience. Any question from the audience side? No question. Thus, this is the session of the opinion of the panel of experts. Sir, Pratap sir.
No, it is well done case actually. There is no confusion about the case.
Yeah. No, I have no comments. I thought you have taken things through very systematically and actually done whatever is needed in this case. You've also spelt out the right messages which are very important.
Yes.
So good. Well done. Thank you.
Thank you, Dr. Aminur Razzaque, for your brilliant presentation as well as the tips which is necessary for doing a rota. Thank you.